Welcome, everyone. Thank you so much for joining us. We will be starting momentarily while we let folks get settled in here. Thank you all for being here today. All right, Randall, I did allow you to talk. So if you can just test to make sure that you can unmute yourself. Hi, Randall.
Okay, I'm here.
Unmuted yourself. There you are. Thank you so much for being here. I'm sorry, everyone. We had some technical issues with Randall, but Randall is on today. So I'm glad that you're here. I'm going to go through my intro slides and we're going to get started.
Okay.
All right. Thank you, everyone, so much for joining us for our Treating Substance Use Disorders in Older Adults with our presenter, Randall Weber. Today's presentation is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this webinar are the views of the speaker and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. We do have a few housekeeping items for you all. If you have any technical issues, please individually message me, Alyssa Kuala, or Jen Winslow in the chat, and we would be happy to assist you. If you have any questions for the speaker, please put them in the Q&A section of your toolbar. The recording and PowerPoint will be made available on our website within the week. If captions or live transcript would be helpful, please use your Zoom toolbar to enable them. You will be also redirected to a very short survey at the end of the presentation today. It'd be greatly appreciated if you could fill that out, and certificates of attendance will be sent out via email to all who attended the full session. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn. We have a YouTube and our podcast channel on Anchor. And I'm super excited and honored to be helping Randall Weber today. Randall Weber has worked in the addiction field for the past 45 plus years as a counselor, program director, and trainer. He has provided training on street drug pharmacology, addiction science, counselor ethics, and substance abuse treatment strategies. Randall has authored or co-authored numerous publications and has held teaching positions at several colleges and universities. He also serves on the board of directors of the Illinois Association of Addiction Professionals. Thank you so much for being here, Randall.
Well, thank you, Alyssa, and I'd like to thank CADC for giving me the opportunity to present today. I'm sorry this can't be under ideal conditions, but I think that we'll get through it anyway. Okay, could I have the first slide, Alyssa? And since I can't see it, does it say who are older adults?
Yep, go ahead.
Okay. So as we can see, there are millions and millions of people who are over the age of 55, even almost as many over the age of 65. Next slide, please.
Randall, every time you say next slide, I'll make sure I got it going for you. So you can keep on talking as you say next slide, okay?
Okay, great.
Perfect.
Let's go to the next slide. So the increase in older Americans has been occurring since the early 2000s. In particular, the baby boomers have swelled the number of people who are over 65. And you can see in a comparison between the year 2000 and the year 2030, which is not really that far away, that the number of older adults is going to swell significantly. Next slide, please. One reason for this is because adults are simply living longer. A person in 1950, born in 1950, could expect to live about 68 years. But now, by 2000, we're almost at 2025, and at that point, a person born that year can expect to live until he's 81 years old. And then it continues from there. Life is simply getting longer. We have miraculous cures and treatments for once incurable diseases, and people are simply living longer. Next slide, please. Now, despite the number of older adults that exist, or I should say, because of the number of older adults who exist, there is an enormous treatment need. It was estimated by the federal government in 1920 that about 4.7 million Americans 55 and older were in need of substance use disorder treatment. Next slide, please. Now, despite this fact, the fact that there are so many people who are in need of treatment, so many older adults, only 18% of substance use disorder programs offer services for older adults. And of that 18%, about 40% offer age-appropriate lectures, about 28% offer special groups, and about 30% offer separate programs. Now, at this point, I'm going to make the argument that older adults do need to be in separate programs. And the reason I say that is because they're developmentally different from middle-aged adults, in the same way that adolescents are different from adults. You would never think of putting an adolescent in an adult group because they're developmentally different, they're emotionally different, their life is different than adults. They focus on school rather than work. They don't generally have families. They're focused on their peer group. And in the same way, older adults are different from middle-aged adults. It's a different developmental period. And so just like programs for adolescents are appropriate, programs for older adults also are appropriate too. Next slide, please. Unfortunately, the number of people working with older adults is inadequate. It just isn't, there just aren't enough people who are entering that part of the field. And many of the older people in the behavioral health field are leaving the field. It's called the graying of the field. Many of you have heard about that. It's simply the fact that many people are retiring and leaving the field, the older people. And so we have an inadequate number of people working with older adults or capable of working with older adults. Some of that may be because of ageism. Next slide, please. Ageism can be applied to any group, can be applied to adolescents. Adolescents are lazy, they're all crazy, or it could be applied to older adults. Older adults don't matter. Their life is over. They're not contributing that much to society. And so that kind of prejudice can influence the people that enter the field and also can influence how we identify and when we identify people who need treatment. Next slide, please. When we talk about the older adults, we're really talking about two different generations. The greatest generation, who would be the people born from 1915 until 1945. These are the people who went through the Great Depression, they fought World War II, then they came home and they started having children, who are the baby boomers, born between 1946 and 1960. Next slide, please. So we have two different distinct populations of older adults, the pre-baby boomers and then the baby boomers. And if you want, you can break the baby boomers down into those born between 1946 and 1950 who are pre-hippie, and those born from 1950 and after who are hippies. The difference between these two is that the people born in 1946 were out of college before marijuana and other drugs became very popular, they were adults before the drug, quote unquote, revolution occurred. And so they're less likely to use drugs other than alcohol. If we compare the two different groups, and this slide got a little bit twisted around, so I'll have to do a little bit of explaining. If we compare pre-baby boomers and baby boomers, some of the differences are that pre-baby boomers focused on teamwork. They had to get through enormously difficult times, and they had to work together to do that. Baby boomers were more focused on individualism. Pre-baby boomers saved money. Baby boomers spent money because they grew up during a time of great affluence. Pre-baby boomers stay with tradition. Baby boomers break with tradition, do something different. For instance, the role of women changed significantly among baby boomers. Marriage first among pre-baby boomers, sex first among baby boomers. Marriage forever among pre-baby boomers, marriage disposable among baby boomers. I'll just go ahead. Drug use was the exception among pre-baby boomers, but among baby boomers, it was the norm. Could I see the next slide, please? What we see here is the number of people who in their entire lifetime had used an illicit drug by year of birth. And what we see on the far left-hand side is that only about 9% of people born in 1930 ever used an illicit drug. We fast forward to the 1960s and 70s, when baby boomers were first becoming adults, entering high school, entering college, and then becoming adults. And you can see that the lifetime use of illicit drugs has gone up incredibly, so that a person born in 1960 had about a 70% chance of at least trying an illicit drug, including marijuana, at some point in their lifetime. Next slide, please. We have seen this focus on drugs other than alcohol reflected in treatment admissions. Here we have alcohol staying relatively flat over a period of about 10 years, and this does end at 2012. One of the things that I have to apologize for during this presentation is the fact that there isn't a lot of up-to-date information about older adults and about treating them and about treatment statistics. As a matter of fact, the National Survey on Drug Use and Health recently came out about 3 weeks ago, and they were mentioning that, it was the Monitoring the Future study. They had been following people since they'd been in high school, and they reported on 35 to 50-year-olds and the fact that drug use was increasing in that population. I gave them a call and said, what about people over 55? What about people over 65? And they said, we don't survey those people. So there is a real dearth of information about older adults, as well as there is a scarcity of services for that population. So let's get back. Drink at 18 to 21 for pre-baby boomers. Drink at 14 to 16 for baby boomers. And of course, that's significant because putting alcohol into an immature brain, a developing brain, and also the fact that the earlier a person starts to use alcohol or other drugs, the more likely they are to have a problem as an adult. Pre-baby boomers go to war. Baby boomers protest war. Pre-baby boomers, cultural stagnation, and among baby boomers, cultural revolution. If you think about all the changes that have occurred in terms of women's rights and the place of women in society, Roe versus Wade in 1970, legalizing abortion, the baby boomers really did facilitate a cultural revolution. Next slide, please. Some of the changes that we expect to see among older adults are greater use of marijuana. And let's have the next slide, because I'm going to say just a bit about marijuana. The CDC indicated about 7 years ago that the greatest increase in marijuana use was actually among older adults. It wasn't among adolescents or young adults. It was among older adults. And you can see these increases of 600%, 400%. The result of this is going to be an increase in cannabis use disorders among older adults. Certainly not everybody who begins to smoke marijuana develops a cannabis use disorder. It's probably about 10 to 15%. But still, when you apply that to the millions of older adults that we have in society, that becomes a very, very large number. Next slide, please. I mentioned this earlier, or I didn't mention it earlier. This is a newer slide. That the average age of first use of marijuana has gone down significantly, and you can see the difference between pre-baby boomers and baby boomers. The year that they were born and then the age at which they first used marijuana. And that's gone down by people born in 1970 to about 16 years of age. Again, we have very young people, very young brains, and marijuana being thrown in there. And then again, the issue of the fact, next slide, please, that generations that experience high levels of drug use during the younger years have more problems. And they use more, and they become more, they misuse and become dependent on drugs more commonly than people who start using it at a later age. Next slide, please. So another change is that we expect to see prescription drug use the same or maybe even higher. One of the differences that is occurring now is that more men are beginning to use prescription drugs. Previously, when people came into treatment, it was majority of women, not a huge majority, but still a majority of women who were using prescription drugs and men who were using alcohol and perhaps other drugs. But in the future, even now as we speak, there is a change in the amount of prescription drug use that occurs among older adults. We also expect to see an increase in the use of other illicit drugs. Heroin and the non-prescription opioids. A lot of this is because of pain. Many older adults have chronic pain. It tends to be arthritis, other inflammation problems, and lower back pain. And doctors are not inclined to distribute opioids now. They're very conservative in their prescription of opioids. And so older adults may be seeking these outside of the medical system, or even making the decision to use heroin. Or in Chicago, where I live, we're really talking about fentanyl. There may also be an increase in cocaine use. And what we don't have here is MDMA, ecstasy. Why cocaine and ecstasy? Well, this has to do with sexuality, sexual prowess, sexual performance. These two drugs tend to increase desire, and surveys have said that people believe that they increase performance as well. And then hallucinogens, particularly psilocybin. Psilocybin is legal now in Oregon. It's legal in the city of Denver, and more states are legalizing psilocybin. The federal government is very near to taking it out of Schedule I with heroin and putting it in a schedule where doctors can actually prescribe it. Many of you know that psilocybin has been used recently to treat depression, and in some cases been used very successfully. That's one reason why older people may take psilocybin. They may be trying to self-medicate themselves to treat depression. The same is true of ketamine, which also doesn't appear on this slide. But ketamine also has been used very successfully to treat depression and often has excellent results even after the first dose. And so again, there are some older adults who are going to try and self-medicate by using ketamine. Next slide, please. Well, we just want to look at some of the psychosocial factors influencing older adults. Next slide, please. These include emotional and social problems, medical problems, and practical problems. Next slide, please. Before I talk about those specifically, I wanted to talk a little bit about Erik Erikson. Many of you remember Erikson from your school, undergraduate or graduate school. Erik Erikson was a German psychiatrist. He developed a theory that there are stages of psychosocial development. And in particular, I want to focus in on older adults. For each stage of psychosocial development, there is a central crisis. And Erikson defined this, next slide, please, as ego integrity versus despair. And what he was talking about in terms of integrity was not trustworthiness or honestness, but rather it was being able to look at the past and accept what happened in one's life versus despair. Next slide, please. So integrity. How do I find meaning in life? Integrity means putting together some satisfying answers to the meaning of life. Why are we here? Why am I here? Why have I been here? And then most importantly of all, looking back on the past and saying, well, there were some bumps in the road. There were some, I had a few challenges that were difficult to get over, but overall, I've had an okay life. I look back and I say, okay, I was there, I did that, and I'm feeling pretty good about it. Next slide, please. As opposed to despair, where a person looks back on the past and says, boy, if I just done this different, if I could go back, I would have changed it. I'm just not happy with the way my life has turned out. I just wish I could go back. And sometimes there's even a momentary split second, almost psychotic thought. But if I could go back to San Francisco where I had that really good job, that really good relationship, I could get it back again. And then of course reality sets in, just in an instant. You can't do that. You cannot go back. It's just not possible. And so integrity versus despair is the central problem among older adults and one that we have to be aware of and take into consideration. Next slide, please. Emotional and social problems, bereavement and sadness, a huge problem, sadness or depression. Often we see this when there is a loss of friends. Perhaps friends die, perhaps they move. Maybe they move to Florida or Arizona or Hawaii or someplace else where it's warm and you're separated from your friends. Family members may die, brothers, sisters, mothers, fathers, uncles, etc. There may be a loss of social status. If I'm not working, what am I? Who am I? Who am I now that I'm not working anymore? Sometimes people who are not working anymore are kind of pushed off to the side. And then the loss of occupation and sense of professional identity, very similar to what we just talked about. I'm not, if I would train and worked as a doctor, as a lawyer, as an architect, as a licensed clinical social worker, and I've retired, who am I now? I don't have that professional identity that was so important to me and that I hung on to. Loss of hopes for the future because the future is foreshortened to some ability. And then the ability to function, to simply get along in the world, to go out and to be part of the world and to be fully involved in life. Next slide, please. We have the sense of being a non-person, a kind of hard to define person. Social isolation and loneliness, a huge problem among older adults. Excuse me. I'm sorry, I just had a coughing fit, had to mute myself. Anyway, reduce self-regard or self-esteem because of changes in life. And again, the fact that perhaps there may be some physical or psychological or neurological deterioration. Family conflict and estrangement. One of the really, really important issues with older adults is grandchildren. If they're separated from their grandchildren, particularly if, let's say, a child says to the parent, you can't see Jimmy because every time you come over to pick him up, you're drunk. That kind of thing, and we're jumping a little bit ahead of ourselves, but that kind of thing is critical to older adults. Their grandchildren are like gold to them. And then another problem is managing leisure time and boredom and being bored. There's just a lot of time. You know, people, when they think about retiring, they think, oh, it'll be great. I can sleep in, I can do whatever I want. I can ride my bike, I can walk, I can go to the gym, I can read more, I can volunteer. But often people who are in retirement are left with too much leisure time and not enough activities to fill that time. Sometimes they're unable to participate in the activities that they used to participate in. And there's a problem with boredom. Medical problems. This consists of, number one, physical distress. Chronic illnesses are very common among older adults, even if they're not life-threatening illnesses. Injury, pain. Pain is almost a constant among older adults. 70% of older adults over the age of 65 have chronic pain. Usually, as I mentioned earlier, something like arthritis or in particular lower back pain is a huge issue. Physical disabilities and handicap conditions of various sorts or another. Insomnia, difficulty getting to sleep but not being able to stay asleep, waking up at 3 or 4 o'clock in the morning and being greatly disturbed by that. You can see how insomnia may be something that would attract a person to a drug that would help them sleep. And then sensory deficits, including hearing. Next slide, please. I'm sorry. Let's advance, Alyssa, to the cartoon.
Randall, we have a question from the previous slide that asks.
Okay, great. Please go ahead.
Great. Somebody asks, can you explain further about the sense of being a non-person?
Yes, I can. Most of us, when, let's say somebody says, what do you do? We say, well, I work at CADC, or I'm a therapist, or something else. And the sense of being a non-person means I don't have an occupation, I'm not doing anything. Sometimes people don't seem to see me. In the grocery store, people cut in front of me and then they say, oh, I didn't see you. And this is just this sense on the part of older people that they almost don't exist. And that's really the crux of what we're talking about when we say a non-person. Do we have the cartoon on the screen, Alyssa?
Yep, I have it showing the comic of.
Okay, all right. So a little joke about hearing, but this isn't just a cartoon. It is also part of the logistical issues that go into putting together a program for older adults. Older adults may have hearing problems. And so how are you going to set up the room? How many people are going to be in the room? Where's the group leader going to be? How can everybody hear properly? Hearing actually, there are two major hearing problems that older adults have, and we'll go to the next slide. Presbycusis, which is simply difficulty in hearing, what they call hard of hearing, and tinnitus, a buzzing or ringing or whistling in the ears that can make it difficult to hear. The fact is that many older adults have tinnitus, and at first it can be very, very concerning. You think to yourself, I'll never be able to hear with all this buzzing in my ears. How am I going to be able to hear people? But the thing is that you can get used to almost anything. And after a while, the tinnitus kind of fades into the background. But the presbycusis, the hard of hearing, is much more difficult to treat. Hearing aids are generally the way to go. Prescription hearing aids cost about $2,000 a piece. Now they have over-the-counter hearing aids now, but the question is whether they are really as effective and as technically advanced as the prescription hearing aids. But hearing is a big problem, so is sight, nearsightedness, presbyopia, floaters, which I won't go into, but cataracts, macular degeneration, which can lead to blindness, and glaucoma, also which can lead to blindness. And then sensitivity to glare. And here we have something that is not just a physical feature. It also influences where and how you're going to provide programming for older adults. When is glare the most serious? The answer is at night. So are you going to start your intensive outpatient program at 6 o'clock and end at 9 or 10? No, because number one, a lot of older people don't want to drive at night. They don't want to be out at night because of glare. And the second thing is that at 10 o'clock, you know where most older adults are? They're in their pajamas. Although we have to be able to provide treatment to people where they're at and taking into account their limitations. Next slide, please. Medical problems include problems with balance and dizziness or vertigo, reduced mobility, perhaps because of a knee or hip problem. And the reduced mobility and the problems with balance also influence where and how we provide treatment to older adults. They're going to be using canes, sometimes walkers, maybe even wheelchairs. Doors have to be big enough for those to fit through. Bathrooms have to be accessible to people who use those devices. Many of these things that we're talking about have direct implications in terms of how we're going to provide treatment. Next slide, please. Oh, cognitive impairment and change. Okay. Which leads us to Wernicke syndrome. Many of you know about the Wernicke syndrome. It occurs in people who drink heavily and are not well nourished. It can include delirium, eye movement problems. Sometimes there's something called gaze paralysis, where the eyes are unable to move, problems with balance, deterioration of nerves in the hands and feet, and the deterioration of the nerves in the feet doesn't help balance and the ability to move at all. Now, again, we have the issue of how we're going to provide treatment to people and having to take into account that some people are suffering from this disorder. Luckily, Wernicke syndrome can be treated with vitamin B1 or thiamine, and it often can be reversed. But if it's not treated and that may occur before the person even gets into treatment. It can progress to Korsakoff syndrome. Next slide, please. Korsakoff syndrome involves some degree of dementia and also memory problems. In particular, what's called antegrade memory. In other words, learning new things. A person with Korsakoff syndrome could read a page in a book, walk away for 10 minutes, and then come back and have no idea that they even read the book. It becomes very serious. And at that point, we have to look at the level of care that we're putting people in. Next slide, please. Menopause and andropause. Andropause is simply the male version of menopause. Next slide, please. So some practical problems. Impaired self-care. Some older adults find it difficult to get into and out of the shower or the bathtub, and therefore they sometimes skip those activities. Reduced coping skills, decreased economic security or new poverty because they've lost their income, their job income. And if they don't have a pension or some money put away, they exist on Social Security, which is very near to impossible these days. So the loss of income can decrease the person's economic security, and then increased healthcare costs can eat away at their savings. Because older adults have so many health problems, they also have costs that are associated with those problems. And Medicare will do some of that, pay for some of that, but not all. And so most older adults have supplemental insurance, which is another cost that perhaps earlier was borne by their employer. And the increased medical costs, the loss of income, all of that can lead to severe financial problems. Next slide, please. Dislocation. Moving to new housing because you can't afford the house that you live in now, it's too big to take care of, or the family moves away and you stay where you are, but your family moves all the way across the country, perhaps to take a job or to take another advantage of another opportunity. Homelessness. Homelessness doesn't necessarily mean being unsheltered. The person could be couch surfing. They could be staying with a relative and then staying with another relative and then staying with a friend. If they don't have a permanent home, and even if they do, sometimes the housing is inadequate. Not enough cooling in the summer, not enough heat in the winter. Perhaps inappropriate for their physical state with stairs or other obstacles that are difficult for them to navigate. Let's stop now and just see, Alyssa, are there any questions at this point?
There are not. Thank you.
Okay. All right, well, then we will continue and we'll be looking at the slide that says common reasons for substance misuse.
Actually, Randall, one just came in right after I said that. Somebody,
Right.
maybe this will be addressed, or this was addressed earlier, but what suggestions do you have for treating clients with short-term memory loss?
Well, the people with short-term memory loss really need to be in specialized programs. That would be the ASEM level 4, medically managed treatment. There aren't any good answers to that. If people can't remember things, it's very hard for them to engage in conversation or discussion in group, or even with their counselor. In that case, we have to move perhaps to harm reduction. Simply, if we can't get the person to the point where they can stop drinking or using, perhaps we can reduce the amount that they're using or move to a less risky drug. But there isn't any good answer to that, really. All right, at this point, we should be looking at the slide that says common reasons for substance misuse. Okay, we have retirement. We've talked a little bit about retirement and some of the problems that can produce. The death of a family member, loss, even the death of a pet, loss of income, financial strain, loss of purpose. If I'm not working anymore, what's my purpose in life? What am I supposed to be doing? Relocation or placement in a nursing home, losing that familiar home, that familiar location where I go. Trouble sleeping, family conflict, mental or physical decline. For example, depression. Next slide, please. I just wanted to mention very briefly that about 4% of older adults are the victims of elder abuse. In Illinois, at least, this has to be reported by mandated reporters. This has to be reported to the Illinois Department on Aging. Elder abuse may be difficult to identify because you don't know if somebody has bruises, whether they fell down, which is common among older adults, or whether somebody was abusing them. Unless the person tells you directly, and they may be frightened to tell you directly for fear of retribution, it's difficult to know. And financial abuse is included, simply stealing from older adults, misusing their funds, etc. Next slide, please. So what are some of the future trends in substance use disorder treatment for older adults? Next slide, please. One of the things that we have now is difficulty identifying clients at risk. One reason for that, or several reasons, is that there's less contact with coworkers, family, and law enforcement. Think about how people who are middle-aged adults get into treatment. Their work performance suffers. They are disciplined because of work performance. Perhaps supervisor says, you know, you have to get back on track. You need to be here on time, get here on time, and stay all day. If you're having problems, we do have someone that you can talk to, an EAP or in-house person to talk to. But your performance has to improve. Well, there's none of that if you don't have work. If the family is further away, there isn't as much contact with the family, less chance of identifying clients that way. And then law enforcement. Older adults are less likely to commit crimes in general. And in particular, a lot of people get into treatment because they get DUIs. I spent about 3 years doing DUI work. And the story in 80% of the cases was I was leaving the bar, I was leaving the party, I was driving home, and I went through a stop sign and I got stopped. What time was it? Between midnight and 4:30 in the morning. The majority of DUIs occur during that time period, when the bars are closing, when parties are over. And so there's less contact with law enforcement and less referral from the law enforcement to criminal justice system. So next slide, please. Because we have difficulty identifying clients at risk, we need more case finding. And because older adults are so ingrained into the healthcare system, doctors, nurses, home health providers, all of them may be sources of identifying people who are having alcohol and or other drug problems. Social workers, senior citizen community programs, even drivers, the people that drive the older adults from the retirement home to the grocery store, they'll notice if Mrs. Johnson is stumbling and smells of alcohol, they'll notice that. And they have to tell somebody because that's a serious physical risk and a risk for the program. And then volunteers of various different sorts. We really have to be creative in terms of identifying and finding those people. Next slide, please. So one of the problems in identifying clients, besides the fact that they don't come to the attention of supervisors, coworkers, law enforcement, etc., is that the DSM-5 criteria may not fit older adults very well. Next slide, please. And then let's move past that. That one talks about tolerance, and we know what tolerance is, the need to take more of the drug in order to get the desired effect. Why might tolerance be a difficult criteria? Well, because older adults may have increased sensitivity to lower intake. Tolerance involves decreased sensitivity to the drug. You have decreased sensitivity, so you need to increase the amount of the drug that you take. Older adults may have a decrease in liver enzymes that break down alcohol, for example, and they may find that they are drinking less, but getting more intoxicated. And so the question is often asked one way or the other, do you find that you need more alcohol or cocaine or whatever it is to achieve the high that you desire? The answer may be no. But no doesn't mean there isn't a problem. It simply means that it's not you need more, it's that you're using less. And next slide, please. Withdrawal. Again, we all know what withdrawal is. So what's the problem with that? Let's look at the slide that says withdrawal. Physical dependence may not have developed. The person may simply not be using enough in order to have physical dependence, or the dependent signs may be so subtle, the way they are with drugs like cocaine, that they're not really labeled as physical dependence. Let's skip this slide that says taking the substance in larger amounts, because that's actually on the slide after. So now we have bold print that says one of the criteria in DSM, whoa, that should say DSM-5. I don't know why it says 4. Taking larger amounts over a longer period than intended, or the desire to cut down, or an unsuccessful effort to quit or cut down. Cognitive impairment can interfere with self-monitoring, and drinking and drug use can worsen cognitive impairment. Next slide, please. And spending too much time to obtain and use the drug, negative effects can occur at relatively low levels of use. And in particular, more free time means less awareness that too much time is lost. If you get drunk at 1 o'clock and at 4 o'clock you kind of sober up a little bit, you've lost 3 hours, but that's not 3 hours at work. That's not 3 hours that you would have been spending doing something else. It's just 3 hours of emptiness for many people. And they just don't realize how much time they're spending intoxicated or recovering from the effects. Next slide, please. I hope that we're on track with the slides. A couple of times I advanced my own slides and forgot to say ask Alyssa to advance the slide. But here we have giving up activities because of substance use, or continuing substance use because there is a physical or psychological problem that's being made worse or being caused by the substance use. Next slide, please. So giving up social, occupational, or recreational activities, there's simply fewer activities. The older person is not going to that Sunday softball game. They aren't going out at night to the book club. There's simply fewer activities, and less awareness that things are being given up. Continuing use despite the knowledge of having a physical or psychological problem that is either caused by use or made worse by it. They may not make the connection. Older adults may think, well, this is because of something else. In other words, I slip and fall, I break my ankle. It wasn't because I was drunk, it's because my balance is off, and it has been for years. And so that's why I fall. It isn't because of the alcohol. And so they may not make the connection between two different things. All right, let's talk a little bit about ESPER. We talked about identifying people within the healthcare system. And a process that's been used very successfully within the healthcare system for decades is called ESPER. It stands for Screening, Brief Intervention, and Referral to Treatment. Next slide, please, that says screening.
Randall,
So
we have
screening,
oh, I'm sorry.
okay, please go ahead.
A question. Somebody asked, since Medicare does not pay for inpatient treatment, what can we do to get seniors help with addiction? Some people do, to all the reasons presented, cross the line for the first time in their lives, need inpatient level of care.
Okay, that's a good question. Medicare does not currently pay for residential treatment outside of a hospital or for intensive outpatient treatment. So we have a huge problem there. If the person is relying purely on Medicare, the only option is to put them in a hospital under the care of a doctor. Now, that doesn't mean that they're not getting substance use disorder treatment. It does mean that the treatment program has to be be in a hospital. There is currently, at least in Illinois, an attempt by our professional organization to get Medicare to start paying for residential treatment. Residential treatment would be, as you probably know, freestanding care. Recovery Centers of America Center in Smithville. And also there's going to have to be an effort to get Medicare to pay for IOP for a number of different reasons. One of them is because IOP is the most common form of treatment for substance use disorders. And also it can be the most effective, particularly when people don't need residential or hospitalization. It's too high a level of care for them, and it can increase their denial. So this is a policy issue more than anything else. It's a Medicare policy issue, and there are attempts right now to get Medicare to loosen up a little bit and pay for treatment in a wider variety of settings. So when we do screening, we may see no problem, moderate risk, all the way up to a substance use disorder. Next slide, please. Brief intervention. This would be for someone who perhaps is at moderate risk. And let me describe a scenario. A woman goes to see her doctor, and the doctor says to her, Ruth, your liver enzymes are elevated. In other words, there's a problem with your liver. It's not working properly. If this continues, it could become very, very serious. It could even end up as cirrhosis, which is the death of liver cells and the liver really becoming unable to work properly at all. That can lead to death. Now, that doesn't mean that you're going to die, but what it does mean is that we should make some changes if possible. Could you tell me, do you drink? If the woman says yes, the doctor might say, well, on an average day, how much do you drink? And then lead the discussion to talk about drinking and the association between drinking and liver problems, and then a prescription. The prescription is, why don't you stop drinking for 3 months, come back and see me, and let's see how those liver enzymes are doing. And a lot of people will follow the direction of a doctor. They will, in fact, do what the doctor says. So brief intervention is just a real quick discussion, giving the reasons for change, motivating the person to try and change the way that they are living their life. Let's see the next slide. Referral to treatment. So this would be for people that do need treatment. This is not early intervention or harm reduction, it's actually referral to treatment. And here we have access to care, and we talked about, just a minute ago, we talked about the fact that access to care can be difficult because of Medicare not paying for many services. Now, again, many older adults have supplemental insurance that will pay for residential treatment. But many other adults just have Medicare. They can't afford extra insurance, and so they are stuck with Medicare. And then identifying an appropriate level of care. Next slide, please.
Randall, what is the
In
title
general,
of the
we
next
want to look
slide?
at the least intense. Listen.
What's the title of the slide you're on? I think I might have gotten a little behind.
Okay. Treatment recommendations.
Okay.
The treatment recommendation in general, no matter whether it's an older adult or not, is the least intensive treatment option. If possible, leave the person in their current environment, but get them into treatment and help them to achieve recovery of whatever that might mean for them. So brief intervention, motivational counseling, and then we move to outpatient, low intensity and intensive outpatient, and then residential treatment, all the way through medically managed. Next slide, please. And naturally, we're going to make these decisions about placement of the person in a level of care using the ASAM patient placement criteria and those 6 different dimensions that are part of that. Next slide, please. Let's talk a little bit about assessment. The first part of assessment has to be a mental status exam, perhaps a brief mental status exam, but something to make sure that the individual is thinking clearly, they're oriented to person, place, and time, and their memory is working properly. It's very difficult to do an assessment with someone who can't remember the last time that they drank. We're talking about a person who has an alcohol problem. They can't remember the last time they drank, or they're not sure where they are at that particular time. So the mental status exam, it can be very short. It can take 5 minutes to do a quick mental status exam. A short Mass G. We'll talk about the Mass G in just a minute. But assessment of social support. What is the level of support among family, friends, the community for abstinence, recovery, etc.? Also, we want to look at exercise. What this has to do with treatment is that we're looking to address a number of different potential problems in older adults. And we know from recent research that a sedentary lifestyle is related to dementia. And so we need to determine how much the person exercises, and if they do, maybe just walking. Walking is fine. That's a type of exercise. And also the diet that they are following, and whether the diet may have something to do with their substance use disorder problem. But let's look at the short MAST. The MAST is the Michigan Alcoholism Screening Test. This is the geriatric version. And rather than read the questions to you, I'll just perhaps mention 1 or 2 of them, and then the slides will be available for you after the webinar. Let's look at the next slide. Have you ever increased your drinking after experiencing a loss in your life? That might be particularly pertinent for older adults. Has a doctor or nurse ever said they were worried or concerned about your drinking? Again, older adults spend a lot of time in the healthcare system, so this is something that may have occurred. When you feel lonely, does having a drink help? Loneliness, again, and isolation is a huge problem among older adults, and so we want to ask a question about loneliness and what their response to it is. Next question, next slide, please. The way that this is scored is, as it says on the screen, is 1 point for each yes answer, and 2+ points are indicative of an alcohol problem, and a B1 should be conducted. That simply means an additional, more extensive assessment. This question should always be asked. The Michigan Alcoholism Screening Test, of course, has to do with alcohol. And of course, we don't use the word alcoholism very often, but it's still in the title of that assessment. But an additional question that we want to ask is whether you take mood-altering drugs, including prescription drugs or any illicit drugs. Next slide, please. Treatment program for older adults, and we'll move past that to the next slide. Types of older adult clients. You can't always categorize people perfectly, but these are 3 different types of older adult clients that you may encounter: the hardy survivor, return to use, and late onset. Next slide, please. The hardy survivor, and on my original slide, I had a picture of Keith Richard. This is a person who has been engaged in long-term drug and alcohol use. They probably have used since adolescent or early adulthood. There's a very good chance that they may have had an AOD problem at some point, and they may have simply stopped using. There are people who, and many people who just say, I'm just tired, I can't do this anymore, I'm going to stop, and they just stop. They don't go to treatment. They don't necessarily go to AA, they just stop. And whether they're in recovery is a question of that could be debated. But there are usually strong connections to the drug culture, even if the person hasn't used in many years. So this is a person that has been using for a long time. Somehow they've survived into older adulthood. Return to use. Prior use of alcohol and other drugs, usually they may have quit in early adulthood, as often happens. Maybe they drank very heavily in college and during young adulthood. But when they got a job, when they got married, when they had children, they just slowly but surely, the alcohol and the drugs began to either disappear or use levels began to decrease significantly. And then return to use because of problems in aging. So the person now restarts their extensive alcohol and drug use. So they begin picking up that joint where they previously had been pretty abstinent for the last 20 or 30 years. Next slide, please. Late onset is the 3rd type of older adult that I'll describe to you. This person may have had alcohol and drug use in the past, but usually no problem. Or they may not have ever used alcohol and other drugs. They may have used alcohol, but not other drugs. But the real bottom line here is that they begin their alcohol use, their alcohol and drug problem occurs later in life. And there hasn't been much of a history of having a problem. There's often significant denial because the person simply, as denial is, just doesn't see the reality of what's going on because of some of the reasons that we mentioned earlier. Mistaking being intoxicated and losing your balance with just general balance problems in general. Let's look at the next slide, barriers to treatment. What are some of the problems that keep people out of treatment? Well, lack of age-specific programs is one of them. Complications with overall health. The person finds it very difficult to engage in treatment because they have severe health problems. Medication management. We'll see in just a minute that most older adults take at least one prescription, and someone has to help them to manage all the medications, because there may be some that are provided in treatment, for example, antidepressants, mood stabilizers, etc. And all this has to be put together very carefully, and there may be some need for help in medication management. Co-occurring disorders, psychiatric disorders, cognitive problems can keep a person from getting into treatment. Transportation. How am I going to get to treatment? If I'm not going to drive, and that may be a possibility, some older people don't drive, or they've had their driver's license taken away, how am I going to get to treatment? In an area like Chicago, where I live, there's the the metro, buses, just a million different ways of getting around. But in a smaller area, smaller city, perhaps a rural area, transportation is not quite as easy, and that could be a real barrier to getting people into treatment and keeping them there. Support systems. Family may not be supportive of treatment, and self-help. The reason I put self-help there is because older adults may not feel comfortable at some AA meetings because they can't relate to the people there. Now, that's a frequent excuse for not wanting to go to AA. Oh, all those people, all they talked about was drinking. It made me want to drink. And there are lots of excuses for not going to AA, but one legitimate one is that the people there, they don't understand me. They don't understand the problems that I have as an older adult. And then often older adults are not seen as a high priority. For example, he worked his whole life. He's older. Let him drink. He's earned it. It's not that important. Or seeing older adults as having less value to society and less need to focus on them and their problems and resolving those problems. Let's look at the next slide. So, treatment recommendations. Pace and content. Let's look at pace and content. Next slide, please. First of all, we're going to look at the guidelines. It needs to be culturally appropriate, and that means that you have to understand older adult culture and the problems and challenges that they face, as well as the strengths that they have. Respect for older clients, broad holistic treatment approach. Because there's so many different co-occurring problems, the treatment approach has to be holistic to span a variety of different issues that may be a problem for the individual. Program flexibility, a slower pace, not going so quickly, taking things easy, shorter sessions and more breaks. One reason for that, a very practical reason, I'll be very honest with you, older adults need more bathroom breaks. And when there are bathroom breaks, there better be enough bathrooms for everybody. So shorter sessions, more breaks, giving people a chance to take care of their needs, adjust for sensory disabilities. So that, for example, if you have 10 people in a group, how are they arranged? You have to be able to see everybody, and you have to be able to hear everybody. And so we have to make sure that the physical setting is appropriate for that. And then consider cognitive impairment. And what do I mean by that? I mean that some people simply won't do well in group treatment because of their cognitive impairment. For them, individual treatment may be more successful because the therapist can go, or counselor can go at a slower pace that fits this particular person, and can do things like writing things down, giving people things to follow along with when they're getting information. So let's go to the next slide. Okay, age-specific group treatment. We mentioned age-specific settings. Location of treatment, near public transportation if possible because of the driving issue. In community-based senior centers, retirement communities, you can actually do treatment or have groups, AA groups in retirement communities. Well-lit parking for those that do park. Older adults often have a fear of crime and of being victimized, and they need to know that they're going to not be walking into a dark parking lot at night. Now, we mentioned that nighttime treatment may not be the best option for older adults, but sometimes it is. Sometimes it fits, and so we have to be flexible. Next slide, please. Age-specific settings. Access to the site, street level access, first floor setting, or an elevator. Stairs are out of the question for many adults. Clear signage so the person knows where they are and where they're going, and building maps for the same reason, so that the person can become oriented and know where they're going, where the bathrooms are, etc. Mobility issues we talked about a little bit. The hallways have to be wide enough in order to accommodate walkers or canes or wheelchairs. We talked about bathrooms. We talked a little about seating in the group room. And it's not only the arrangement of people within the group room, it's also the type of chair that people sit in. You don't want to put an older adult in a chair that you have to heave yourself out of because they may not even be able to get up. And then sensory issues we talked about already, the need to be able to hear and see other people as well as the group leader. So older adults versus younger adults. That is the next slide. I'm sorry, I keep forgetting to ask the slide be advanced. Less confrontation, more support. Older adults do not respond well to confrontation. And confrontation in general is not usually a helpful thing in treatment, but there can be some gentle confrontation. In older adults, it has to be very gentle confrontation and a lot of support. A focus on decision-making. Be polite to the person. Use their surname at least once. If you're 40 years old, I would not call a 75-year-old Jack the first time that you see him. I would call him Mr. Smith. May I call you Jack? And this is part of respect for older adults. Grandparent. Older adults are often grandparents, and I mentioned the influence of grandchildren on them. I worked with a man one time who was just dead set against drinking, angry that he was in treatment, and I asked him to write a letter to his granddaughter explaining where he was, and he never got it done. He came out and he said, look, I need help. I can't see my granddaughter unless I get some kind of help, and I need that. So can they see their grandchildren? Can they have custody of them? In other words, can they see them, stay with them, have them sleep over? And then be aware that death is a frequent theme. Nobody likes to think about death, but it is there in the minds of older adults. It's simply an issue that they can't ignore. I take note of when people pass away, And the last one I remember is Jimmy Buffett. But that was significant for me because, to be honest, we're almost the same age. Sample topics for group discussion. Death and dying. That doesn't have to be quite as morbid as it sounds, but it is an issue. It has to be addressed. Grief and bereavement, anger management is kind of a staple in treatment. It's not just for older adults. Who am I now? That issue of being a non-person, what's my identity, my legacy. What am I going to leave behind when I'm gone? This is something that many older adults think about. After I die, will there be any evidence that I even existed? Will there be, can I leave my values to somebody, my knowledge to someone? Careful use of medications because of the large number of prescription drugs that people use, and then managing pain because pain is so often a part of being an older adult. Well, let's have the next slide. So treatment approaches. These are familiar to you already. CBT is the most common form of treatment for substance use disorders, motivational enhancement, group-based approaches, et cetera, et cetera. Let's move down to the last bullet point on treatment approaches. Case management and community-linked services and outreach. There has to be linkage to other services within the community that serve older adults, and those might be in the next slide where it says linkages. Medical and healthcare agencies, physicians, all kinds of different healthcare professionals. Visual and hearing impairment resources. Where can I get a hearing aid? How do I choose? How do I know? How do I get money to help pay for it? The same with glasses. Linkages to senior centers. This can help people to stay more active. Retirement communities, for those people who are at a point where they need to move from their home to another community. Animal welfare organizations. Why did I put that there? Well, two reasons, and they're called in and out. One of them is that older people often find comfort in having a pet. Someone who loves them, someone who needs them, someone that they can talk to in many cases. And that's the in part. The out part is a little less happy. Sometimes older adults are unable to care for their pet. They just can't do it anymore. And they have to give up their pet. And so there have to be connections to places that will take that pet and hopefully rehouse it. And then transportation resources. We talked a little bit about public transportation, and if there is public transportation, is there a senior fare? Is there a senior card that you can get? This is true of all different resources in stores, medical facilities, any place at all. Is there a discount for seniors? My friends tell me there's even a discount for seniors at the marijuana dispensaries. Okay, let's advance the slide to treatment goals. Eliminate or reduce substance use. If we can't eliminate substance use, let's try and bring it down. Safely managing intoxication episodes during treatment. These episodes do occur. Relapse is often part of recovery. And those intoxication episodes have to be managed in the sense that the individual has to know ahead of time, if I become intoxicated, this is what I need to do. I need to let somebody know. I need to be in a safe place so that I don't hurt myself or someone else. Another treatment goal is enhancing relationships, kind of ending that loneliness, that isolation, promoting health in general, and stabilizing and resolving comorbidities such as psychiatric disorders, cognitive impairment. There are medications that can be given to people that have dementia, whether it's Alzheimer's disease or Lewy body dementia or whatever it might be. There are medications that can help them. And so assistance in resolving that kind of comorbidity is very important. The next slide says substance use disorder medications for older adults. And we'll move past that. And I can just mention that these medications that are listed on this slide, where it says pharmacological therapies, they all have a strong basis of scientific evidence. The research has been done repeatedly on methadone, naltrexone, bupropion, which is also called Wellbutrin, nicotine replacement therapy, and buprenorphine. A lot of research has been done. Not on the elderly, though, not on older adults. We really don't know very much about the way that these medications affect older adults. And so we're in a field where medication can be critical. We have a gap where these medications may not be prescribed or dispensed because of the lack of information about how they work on the elderly. Okay, let's go to the next slide. Creating a treatment environment responsive to older adults. I'm not going to read these to you. I don't like to just read words from slides. But in general, what are some of the rules for creating that treatment environment? Understanding developmental needs and cohort differences. The differences between the pre-baby boomers and the baby boomers, the differences between the ones that began smoking marijuana in college and the ones that were out of college by the time marijuana became popular. Organizational self-assessment of whether people in the organization have the skills and the knowledge in order to treat adults. Look at the physical environment, make sure that they're accessible to older adults. And then organization-wide competence in developmental needs of older adults. And cohort differences simply means the difference between different generations of older adults. Next slide, please. You can, if you want to, assign one staff member to oversee the development of age-specific programs. You could develop an advisory board, including older adults from the community. Engage clients, staff, other people, community in planning and developing. And be able to make sure that all staff are responsive to older adults' needs, at least to some extent. Not every staff member has to be capable of providing treatment and being one of the treatment providers, one of the staff that provides treatment. But everybody, including the receptionist, should have some idea of what policies and procedures are for managing older adults. Okay, let's go to the next slide.
Randall, we have a question.
Oh, yes, please, go ahead.
Somebody asks, what about the individuals already on methadone and are aging?
If the person is already on methadone and they're aging, they need to be very closely supervised by a doctor. One reason for that is because there's some cardiac issues related to methadone that can intersect with natural heart disease as the person gets older. I think what we're talking about is what's called an elongated QT interval, which a doctor would understand and which has to do with the way that the heart functions. So the answer would be, if they've been on methadone, there's no reason to take them off of methadone per se, but they have to be seen by a doctor on a regular basis in order to make sure that there aren't side effects that are negatively affecting their function. The other thing is that I'm a big fan of moving people from methadone to buprenorphine. But again, buprenorphine is not has not been tested extensively on older adults. So methadone in general is okay for older adults, but the doctor has to monitor them very carefully. So, creating a treatment environment responsive to older adults, going on with that. Developing an environment that enhances engagement and retention of clients. Just like with adolescents, you have to have an environment that is supportive, familiar, friendly to older adults. And develop outreach strategies because it's so difficult to identify those people, and we need to engage many different types of people in identifying clients and improving access to care. Next slide, please. I'm watching the time very carefully, and I think that we have time to talk about substance abuse profile for the elderly. This is something that you can buy. It's free. It's published by the Center on Substance Abuse Treatment. The publication age is 2005, and so it's 18 years old. What this shows you is that publications, research, methods are lacking for older adults, and many of them are very, very old. A lot of the research that I do ends at 2014, 2017, and there just isn't a whole lot of literature on older adults. Sometimes you have to use some of the older publications, such as this one. And if you go to CSAT, just Google Center on Substance Abuse Treatment. They should have an area where they have publications and where you can order this if you want to. So SAP is substance use and treatment history and a substance use and behavior chain. Okay, let's go to the slide that says substance use and treatment history. This is for people who have known to have used a substance. There's no point in asking about substance use and treatment history if the person has never, if that doesn't apply to the person. The substance use and treatment history basically is providing a roadmap that shows where the person has been and gives you an idea of where they should go from there. The substance use and behavior chain is the things that are on the screen right now. Recent substance use, things that occurred after substance use, consequences of use, and motivation for treatment are all part of this particular guide. When answering questions, the client is provided with a 30-day calendar. This will help them to identify whether this was a week ago, 2 weeks ago, etc. If you have something that is right in front of them that helps them to remember when things happen, it's very good. The other thing is that when you're asking questions, let's say it is a structured or semi-structured interview where you ask specific questions, such as for a person who drinks, in the last 7 days, would you say that you have consumed alcohol every day, every other day, several times, or not at all? And those answers need to be on cards because the person may not be able to remember all the answers that you just gave. So 4 or 5 or 6 cards that have common answers on them. And we're going to use card 3 now. And using that card, could you tell me when the last time that you used alcohol was? Was it? And then the answers are on the card, and it helps the person to keep track of what's happening. Let's talk a little bit about addressing prescription drug misuse. And let's go to the slide that says elderly persons use prescription medications about 3 times as frequently as the general population. This is a major issue for older adults, is prescription medication. Next slide. 80% of people between the ages of 57 and 85, 80% take at least 1 prescription medication, and 50% take 5 or more medications. They may get them from 1 doctor, 2 doctors, 3 doctors. Does the other doctor know that the first doctor prescribed this drug? Are there interactions? There are all kinds of different problems that can lead to prescription drug misuse. Next slide, please. You see on TV, if you watch TV, all the ads for medications. And the idea is this medication is good for you. Talk to your doctor about getting the medication. And about 30% of people, Americans, talk to their doctor about something they saw advertised, and less than half got the prescription they asked about. But 44%, that's a pretty high percentage when you're actually the one asking the doctor for the prescription. Let's look at the next slide. So people are asking doctors for medications, and a little less than half of them are actually getting the medication. A little more in the way of statistics, 1/4 of all prescription medications prescribed to people 65 and older. And it's estimated that about 11% misuse prescription drugs. Misuse is what we used to call abuse. We don't use abuse anymore, but misuse. They purposely take more of the medication than they should, more often than they should, mix drugs that they're not supposed to mix. And a larger number than that 11% simply don't follow the directions. And it's not that they're obstinate, it's just that they have difficulty following directions. They may not be able to read very well the directions on the prescription bottle. Next slide, please. So how do we prevent prescription drug misuse? Well, prepare for the doctor's visit. Make a list of all the medications, including over-the-counter drug, or bring the bottles with you. Write down all of your concerns and complaints. So you're going to show the doctor all the medications you're taking. You're not going to rely on your memory. You're going to have a list that you can hand to the doctor, so the doctor can look at it and say, well, wait a minute, I didn't know you were taking that. Or these two may interact badly. Get information from the doctor. Don't let the doctor rush the exam. The doctor is there to see you, to deal with your health problems. Don't worry about wasting the doctor's time. A lot of older adults that I work with say to me, well, the doctor's so busy, I just didn't want to waste his time. I did have a question about this medication, but maybe I'll ask him next time. Next slide, please. Some of the questions that older adults need to ask their doctor is, why am I taking this? And what am I taking? Why am I taking it? What is it for? How long will I be taking it? Is this a temporary thing, or is this something that I can expect to take for the rest of my life? Side effects, special way of taking the drug. Should I stop taking other drugs? And the person has to be honest about, and the doctor has to be asking about illicit drugs as well as other prescription drugs. So, what can I do now? What can you do now? Be aware of attitudes and beliefs regarding aging. Get some education. Find out about the developmental issues affecting older adults. Understand psychopathology in older adults, the occurrence of psychiatric disorders, how that may manifest itself on older adults, as well as some of the disorders such as dementia that are primarily found in older adults. In terms of assessment tools, Be familiar with them. Learn how to use them and how to interpret them. Learn about the efficacy of interventions. How successful has this intervention been? Has there evidence-based? Is this an evidence-based practice? Is there research behind it? If there's not, you may still have to go ahead, because I mentioned earlier that there are very little research about older adults. Gain additional training on gerontology. This is similar to what I mentioned earlier about really learning about developmental issues with older adults, what their life is like, the problems that they have, the challenges, as well as the strengths that older adults have. Because there are strengths that older adults possess that don't occur in younger adults. And then encourage the development of older adult programs. Well, we finished a little bit early. Alyssa, any questions from people?
Don't have any questions at the moment. And if anyone want to put any questions in the Q&A section, you're more than welcome to. We'll give it a couple minutes.
Sure.
They come up.
While we wait for questions to come in, Randall, I just want to say thank you so much for working with us with all the technical difficulties. This presentation was absolutely fabulous. And again, please put any questions that you have in the Q&A section so Randall can answer them. We will be adding the PowerPoint and recording to the Great Lakes ATTC website under a product page. So you can watch for the recording. Should be up within the week.
We have a question that came in that asks, how can we contribute to evidence-based research for SUD recovery in older adults?
Well, if we're talking about evidence-based, that refers to developing a research model and using different techniques among older adults compared to treatment as usual, which is perhaps what you're doing now, and looking to see whether the new strategies that you've developed work better in terms of what percentage of people are abstinent after 1 year, how many people are in recovery after X number of years. Developing treatment strategies also has to do with how the clients feel about the treatment. Surveys among older adults that help you to understand whether what you're doing is hitting the spot, is something that is acceptable and palatable for older adults. But evidence-based treatment does require doing research and comparing a particular treatment technique with another one. And like I said earlier, it's usually what's called treatment as usual. So that, for example, you might have a treatment program that's very successful. It's used primarily with younger adults, and by younger adults, I don't mean emerging adults, people between the ages of, let's say, 18 and 25. When I say younger adults, I mean younger as in 35, 40, 50 years old, that age. Comparing treatment with that group against treatment with older adults, the treatment that you provide to the younger adults, compare that to the new treatment approach that you've determined for older adults, and then again, you look at outcomes. and determine what the outcomes are in the different strategies, different treatment approaches. This is something that GLADC has very good connections to researchers. And if you want to know more about evidence-based treatment and what it is and how it occurs, I would contact GLADC and then ask, who can I talk to? Alyssa, anything else?
Yeah, somebody just asked, you mentioned there is a push to create Medicare policy change to get residential treatment covered. Is there a way to get
Right.
involved in that work?
Well, I only know about it occurring in Illinois. I haven't talked to the agencies in other states that GLADC serves, as well as the entire ATTC network, to find out what legislation is occurring in those states. In Illinois, I would contact the Illinois Association for Behavioral Health, Illinois Association for Behavioral Health, and ask them about some legislation that they are developing to encourage Medicare to provide residential treatments for older adults. Otherwise, I would go to your professional association and just say, this is a problem. We don't have all the levels of care available for older adults that we need. And there must be some way that we can influence a policy, Medicare policy. Hopefully what's happening in Illinois will be successful. I don't know exactly what it is. I know that it's being developed now. The policy and the sample legislation. But you might contact, again, Illinois Association for Behavioral Health and just ask them, what are you doing? What's going on with you? And that's going to progress as time goes on, as the process becomes it begins to follow its own path. So that's what I would say for that. Right now, I'm not really sure who's working on it outside of Illinois.
Somebody asked, I accidentally dismissed it, but they asked what you were, what GLADC you were referring to, and he's referring to the Great Lakes ATTC. That's us who is putting on this training, and we put our website into the chat and into the Q&A.
Yeah, I apologize for using that acronym. Yeah.
As of right now, I don't see any other questions in the Q&A.
Well, thank you so much again, Randall, for being here. Thank you, everyone in attendance today. Again, I will reiterate some of the reminders that Jen put in the chat. The recording and PowerPoint will be available on our website within the week. You will be redirected to a very short survey at the end of today's presentation, and we would greatly appreciate it if you could fill that out. The link is also in the chat. And then certificates of attendance will be sent out via email to all who attended the full session today. They will be sent out again via email in a PDF form, and it will take about 2 weeks to receive your certificates. So if we don't have any other questions, Randall, again, thank you for being here. Thank you, Jen and Jean with the Great Lakes ATTC for being here and putting this webinar on today. And we look forward to seeing you all on future trainings.
And all the webinars put on by Great Lakes are excellent webinars, and I recommend them very highly. If any of you want to get in touch with me, you can do so through my website. randallweber.com. 2 L's in Randall, 2 B's in Weber. Any questions that you might have that you didn't get answered, that don't get into the Q&A or help in developing a program, I'm always available. I'd be happy to talk to you. Okay, thank you, Alyssa. Thank you for being such a great moderator and for setting up the whole program.
Of course. Thank you, Randall, and thank you, everyone. Hope you have a great rest of your week. Bye.
Goodbye, everyone.